engage in healthcare, we have some role in trying to work with those hospital systems or those organizations or those providers, or in some cases pharmacists, to do better, to do more, to do differently. So what I'll talk about today is one particular project within that whole scope, and it is focused on opioid safety. This I like because it is perfectly representative of what it's like to work for the federal government. Okay? Everything is an acronym. Every acronym changes 3 or 4 years, and a whole lot of effort goes into mapping how these acronyms work together for some grand design. So I put this up here not to necessarily elucidate anything for you, but to give you some small window into the complexities of working in a federal contracting healthcare system. We work with dozens of other related quality improvement focused organizations through various layers of CMS and Health and Human Services. And it can be messy, and this is a good example of it being messy. But I also like that this graphic shows something which is really important at the heart of what we do, which is trying to put the patient at the center of everything. So trying to make your goals for what you're trying to do patient-centered. Trying to get the delivery of how you make some improvement happen to put the patient at the center. So I thought it was a good representation of that. I mentioned a lot of things that we've done, and in Georgia, this is just a snapshot to kind of, again, give a little context. Who are these guys at Align Quality that operate as a Medicare Quality Improvement Organization? So in the past, these are some of our areas of focus. Reducing healthcare associated infections, improving nursing home care, a lot of work with physicians on transitioning to a fee for quality instead of a fee for service-based payment model. So how do you then measure somebody's quality? And how do you train providers on what those measures mean? How do you help them to do a better job of doing the work that factors into what is being measured? So this is all kind of our role, and it transitions over time as a subject becomes more mature, that we move from educating on just what the heck is the federal government talking about when they say quality payment, to these are the measures, to this is how you do it, to this is how you do better. And ideally, we spend most of our time in that last little part of this is how you do better. But you don't get there until you've done all those other parts first. And I think we'll see a little bit of that as we talk about this naloxone project. So I would love if I talked less and y'all talked more, but I was hired without pay to come talk. So I will do most of the talking, but I'm going to ask you all to throw in your words as much as you can. What I tried to bribe Henry into considering was that if y'all would give responses, questions, or answers, that you'd be exempt from today's pop quiz.
Okay.
Oh, I just ruined the surprise. There's a pop quiz, right? So I'm not sure if he's agreed to that principle or not, but that's the notion we're working on right now, is if we can log the fact that you participated in today's conversation, you're exempt from today's pop quiz. Sound fair? Let me hear it louder. Sounds fair?
Yes.
Yeah, I have some of you over there in Savannah or Augusta. Thank you. Sounds fair. So, without me then belaboring everything that's on these slides, let me hear it from you all. Why are we worried about opioids? Why is that a conversation? Because they're overprescribed. Okay. Why does that matter?
They're dangerous.
They're dangerous. What do they do? How do they kill people? Probably in some rare instance there have been fatal constipation cases, yes, written up in the literature.
Respiratory depression.
Respiratory depression. Who's at risk? Not good. All right, Henry, we did good. No, don't give it away that easy. All right, you all know this, so I'm not going to belabor these points. We know what opioids are, right? We establish that there's risks. We establish that those risks are present for anyone who encounters those opioids. In particular, the risk we're worried about is respiratory depression, which can be fatal. Fantastic. We're all on the same page. What is naloxone? A reversal agent. What does that mean? Okay, we got specific. I like that. Pulls the opioids off the mu receptor. Why would we do that? Okay, why would we do that? So they don't die of constipation. That's right. Life-saving constipation interventions can be achieved with the power of naloxone. Very good. Pretty much, right? So naloxone is used in an emergency. It is used to revive somebody who is experiencing an opioid overdose. And in particular, the reason we're using it is to stop that respiratory depressive effect of the opioid. So, naloxone, what are some brand names that we might also hear interchangeably for naloxone? Good, Narcan. Is there something else? What are the forms of naloxone that are available? How's it administered? Nasal spray. What else? Injection. All right, so primarily that's what we'll be talking about in the community. Naloxone can be used intravenously, but that's largely just going to be in a hospital setting, and typically after some bolus dose given by a nasal spray or by an injection. Perfect. All right, so we got the right ideas here. Naloxone used to save lives, and we know. Oh, look at that. I'm asking you all questions, I gave you the answers. It's too easy. Evzio is the other brand name I didn't hear, and that's an auto-injector. So, when we're talking about the opioid problem, right, we know that there's an opioid problem. We just defined a little bit about why it's a problem, why are we concerned about it. I haven't talked a whole lot about, but I guess I will in a moment, about the scale and the reasons why we're really focused on this being a problem. But at the root of any effort to improve healthcare, to improve any process or any service delivery, is these two questions. What's the problem? And what's the solution? Hopefully the best solution. But this question isn't really the end all. It's just the beginning of a series of questions that we need to ask. But all of them are intended to provide some clarity to this right here. What's the problem? We have to understand that pretty intimately to have any confidence that what we're going to do about the problem is going to actually work. So when we say what's the problem, I heard y'all say overdoses, deaths. I heard you say respiratory depression, and constipation certainly was mentioned as well. Okay, is that enough? I mean, there's other things that cause people to die, right? There's other things that have serious health effects. Why are we talking about opioids? Because they're addictive, highly addictive, okay. Why else?
Haven't they exceeded motor vehicle accidents for cause of death? For,
yes, I think that was just in the news 2 days ago, maybe, very current, that the rate of deaths of opioid overdose has exceeded motor vehicle accidents in the United States.
I am impressed.
Yeah, right, really good. So that right there is the nature of the issue itself. The fact that opioids have risk, okay, so do other drugs. The fact that they're addictive, okay, so what? Other things are too. The fact that people die from it, well, that happens, you know. But the fact that more people are dying from opioid exposure than motor vehicle accidents should make us sit up in our chairs and think, what is going on, right? So that is why this climate of the opioid crisis, you know, is really the nature of the conversation around opioids right now, because of the scale of the impact. So we think about what's the problem. We've got a lot more questions that stem from that. You know, what are the causes of this problem? How many people are affected? Who's affected? Why are they affected? Why some more than others? Right? So this litany of questions comes to mind that helps us clarify and add some understanding ultimately to this issue of what's the problem. So let's talk just a little bit about that. I know that probably a lot of this is familiar, so if it seems like I'm breezing through this, it's me just trying to be deferential to y'all and thinking that you probably understand a lot of this or you're going to grasp it really quickly. These numbers were from a couple of years ago, just 2017, and already the 2018 numbers are blowing them out of the water. 42,000 plus deaths in 2017 from opioids is more like 58,000, I think, in 2018 right now. So that's where that new data is coming out that says more deaths than motor vehicle accidents. But the scale of exposure, the scale of addiction, dependency, the cost on our healthcare system and beyond is really staggering. So I like to show this slide because I think it really starts to bring some of the point home. This blue line here, steadily kind of increasing, is the rate of deaths related to opioids that are prescribed. And here's what I think there are some interesting challenges in how do we address this problem within the healthcare community when it is a problem that extends far beyond just our reaches or our impacts or the patients we serve in the medical community. So this is prescribed opioids. There's clearly a connection between what we do as healthcare providers and this line here. But I don't dispense a whole lot of heroin. I don't dispense a whole lot of powdered fentanyl, right? Do we have anything to do as healthcare providers with these little lines over here, my teal line and my red line? I see a nod. I'm looking at you. You know I'm looking at you. Tell me why you're nodding. Perfect. Really good answer. So if y'all didn't hear that, I'll just try to restate it. Tell me if I went astray. But we've been prescribing opioids, and then we tighten it up, or it just becomes harder to access, or they become more expensive, or your doctor stops seeing you, or you move to another town, whatever the reason may be. You're an opioid user, you become habituated to it, now there's a disruption. And this shift that we're seeing, although the prescription opioid line is still going up, you see right about here it starts to level off. And right about here, we start to get heroin coming in more and more. And just recently really has the problem come up that the fentanyl-laced heroin is causing so many deaths. So fentanyl as a powdered, abusable form really wasn't something that was exposed in the market more than just a few years ago, but now the supply is here, it's cheap, it's readily importable, it's readily distributable, and as the point you made, I think in conclusion was, it's extremely potent and people are using or being exposed to a dose of opioids that they aren't accustomed to, or that can't be accurately predicted. And that's really the nature of what's driving 50,000+ people of dying. It's not all prescription opioids. In fact, it's not even mostly prescription opioids. But it's all connected, and we can't ignore one for the other. And what I hope that we'll talk about as we go along in describing this intervention that I've worked on is that it has, at least to some extent, some service on all three of these lines. That there's an opportunity within our healthcare realm to be helpful for those patients who are really experiencing a problem that is outside of the realm of healthcare. But we do have an opportunity to be helpful in that. So, the exposure to opioids, the causes of harm are massive in scale. So it leads me to think in the notion of, what's the problem and what are these lead-on questions that we want to answer to define it? Well, let's learn more, right? Who are the people? Now, I work for Medicare. And that means that primarily I'm asked to focus on Medicare people. So in some senses, I can answer this question before the question's even asked. Who are you worried about? Well, I'm worried about Medicare people. I'm worried about Medicare people because that's my job. And that's who pays the bills. Okay, fair enough. But within that realm, there's still lots to learn. Who's at the highest risk? What does the exposure look like? Where is this happening? So this is something we do a lot of in my world, and working the quality improvement organization, is that we have access to essentially the whole realm of Medicare claims data for the states that we work in. So I can see all the Medicare Part A and Part B claims. I can see all the Medicare Part D claims. And with that information, we can start to make some corollaries. We can start to dig into it and analyze it. And this is something we did in analyzing it, which is looking at, for Medicare beneficiaries who use opioids, what are the rates of hospital readmissions? And I've got a bunch of these maps. I'm only going to show this one and another one. But what it tells us in looking at readmission rates, so this is somebody who uses opioids who's been discharged from a hospital and returns to that hospital within 30 days. That's how we're defining readmissions. Opioids are certainly a contributing factor that opioid users have much higher rates of readmission than non-users. But where's it happening most often? And what we see pretty clearly in the data, you may tell that this is Metro Atlanta, and the side of this dark line here. This is downtown Atlanta. This is kind of the northern suburbs, Marietta, Alpharetta, Gwinnett. But there's a real concentration, Augusta, some in Savannah, Macon area, that the metro areas of Atlanta tend to have the highest rates of opioid-related readmissions. Okay, we're learning something. We look at rates of opioid exposure across the state and map that out. What zip codes have the highest rates of opioid prescribing? And what we see pretty consistently, not just in Georgia, this in a lot of states, our rural areas have higher rates of opioid exposure. Anybody work in a pharmacy in a rural area, back home or here, even just outside of town a little bit? What's your experience with people using pain medicines? There's a lot. Yeah, so when I was in school, I worked in Watkinsville, which is certainly rural enough, and the clientele served at the pharmacy I worked at were from all, the surrounding regions. I was astounded by the opioid exposure, the percentage of people who use opioids. The numbers that got their 120 or 180 Lortabs every 26 and a half day, like clockwork, right? So it's not a surprise to us necessarily if you've worked in the field that that's the case. But the data certainly backs it up quite clearly that the more rural a county or zip code, the higher the rate of opioid exposure. So why am I asking these questions? Why am I looking at this information? Well, what it tells me is a little bit about opportunity and need. Right? Who's affected the most significantly? Where is that effect concentrated? So that if I'm going to use limited resources to try to make a difference, how can I target it to the area which I think may have the biggest impact, the most significant improvement in what we hope to improve? And ultimately what we're hoping to improve is reducing deaths related to opioids, improving the safe use of opioids. Oh, I might have just answered a question. What's the problem? Okay. What's the best solution? So, y'all tell me. Opioids are a problem. We heard overprescribing is an issue. We know the causes. We know why those causes are significant. We know the scope and scale of the impact of all of those causes of opioids being a concern. What's the best solution? Who knows about some things that are going on that are trying to address our opioid problem?
Prescribing guidelines.
Oh, thank you, student Henry Young. I appreciate your input. Other students? Prescribing guidelines. So educating people on what is appropriate prescribing of opioids. What else?
Insurance limitations.
Insurance limitations. Okay. So some barrier to obtaining beyond a certain quantity or maybe beyond a certain dosage if it's prescribed. What else? Improve monitoring. How do we monitor? Good, okay. So there are statewide databases that tell you that Ms. Smith got her opioids somewhere else last week, or wherever, or that isn't the case. There's an additional information available to us to give us a complete picture about somebody's opioid exposure. What else? Perfect, okay. So just better education. Maybe that's public education, PSAs. Maybe that's trying to incentivize or encourage our prescribers to do a better job of educating when an opioid is prescribed, or pharmacists to do a better job of counseling when an opioid is dispensed. Fantastic. So there's these initiatives kind of all over the map of how do we intervene to try to do better. And I'll talk about one of them, and the one I'm going to talk about is about promoting the use of naloxone. So you may or may not know this, but there's a standing order in Georgia. In fact, there's a standing order, I want to say at last count, it was like 44 or 47 states, that there's some mechanism of making naloxone available without a prescription. Does anybody know about this in Georgia? Has anybody worked in a pharmacy where you've dispensed naloxone using this standing order? One hand, 2, 3 hands, 4 hands, a podium in Savannah? Okay, not sure about that. So a few of you have used this. That's fantastic. I'm really glad to hear that. There's essentially a law in place that says anybody who wants to obtain naloxone can walk into a pharmacy and request it just like you could a flu shot. And ideally, just like with a flu shot, you would walk out the door having received what you wanted. That's what the standing order allows, and that's what it's intended to do. And I bring this slide up really just because of this bottom section, which was in this publication from the Substance Abuse Research Alliance in Georgia, which is kind of unofficially the official scoring agency, in a sense, for how Georgia is implementing on a state level policy around opioids. So this group suggests things to the governor, to the legislature, to state government agencies, and then what I'm reviewing here is a kind of what they call the scorecard, so the review of the past couple years of efforts, how we're doing. And the number one policy recommendation was increasing access to naloxone. So at the time that was written, it was, hey, let's pass a law that looks like a standing order. That means people can get access to this drug to save lives. Now what it looks like is, okay, we passed a law, and it's on the books, and what else has happened? What else can we do? What else do we need to do? And where I think Georgia has not done as well as other states is in that what's next. We haven't done a great job of messaging about this. We haven't made it much of an impact in terms of public service campaign kind of announcements to make the common man, public aware of this law, what it means, and how you can use it. We haven't done much to educate prescribers that their pharmacists they work with can dispense this. We haven't done much to educate pharmacists on how to use a standing order. What are your protections? What are your concerns? Anything like that. We haven't really done a whole lot in terms of moving this forward. And, this is kind of throwaway slide. Okay, naloxone stage lives. This is what we're going to talk about. Hint, hint. We're going to talk about naloxone today. This is our intervention. We want to dig into this a little bit better. Recognizing, didn't seem like Georgia's doing a whole lot to educate about this. Didn't seem like there's a whole lot of a campaign around the fact that this law has been passed, whereas in other states, certainly there is more of that. Well, what does that look like in reality? So again, I mentioned I work in Georgia and North Carolina primarily. Here's kind of head-to-head comparison. North Carolina's on top, or Georgia's on top, North Carolina's on the bottom. And what we looked at was, from Medicare Part D claims, all of the pharmacies in the state who bill to Medicare, of them, how many have billed a claim for naloxone? And in North Carolina, which is about maybe 6 months ahead of us in terms of implementing this law, but I think leaps and bounds ahead of Georgia in terms of educating the public and the healthcare providers on this law, we see something very different than when we look at Georgia. So what I looked at was, okay, of all pharmacies, how many have dispensed any naloxone? In North Carolina, that's almost half. So out of, that's like, oh gosh, I'm going to lie if I come up with a number, but that's hundreds. That's like 900 something or 1,100 pharmacies assessed. Half of them have billed at least one claim for naloxone. In Georgia, less than 9%. So fewer than 1 in 10 pharmacies have ever, at least in the Medicare population, dispensed this medication. And then digging further into that, okay, so some are doing it, some aren't, most aren't. How much? And again, these numbers I think really starkly show a difference between the two states. That in Georgia, the vast majority of that less than 9% that have dispensed any naloxone have only dispensed one dose. Very few have dispensed 2 or more doses or 5 or more doses. And again, in North Carolina, done a better job of promoting this, done a better job of educating the public on its availability. Those numbers are really staggeringly different, that the majority of pharmacies that have dispensed any naloxone have dispensed a lot of naloxone. So, we've defined the problem a little bit further here. All right, we know there's a need because opioids are risky. We know that that need is significant and worthy of our attention because that risk is translating to massive scales of death. We know that there are responses, and that in fact one of those responses has risen to the top of policy recommendations from this trusted entity, the Substance Abuse Research Alliance. And now we know a little bit about how much of a problem this is. What's the nature of it? Who's affected by it? Who isn't? And we can dig further into it. And I won't belabor this point a whole lot further than to say, we looked in breaking this down further into communities around the state. We saw that there's an almost perfect alignment between the higher the rate of opioids prescribed, the lower the rate of naloxone dispensed. And that's backwards, right? Intuitively, those ought not to be coexisting. If there's more opioid exposure, if there's more risk, if there's more patients taking high dose, there ought to be more naloxone. And in fact, the opposite's true. And that informed us in our project a little bit about targeting. Where do we want to reach out to? Who are the groups we want to try to recruit into this initiative? I'll make this last little case about why this matters. So this will be my last little data display. And this was another analysis that we wanted to look at and define. Why do we need to do this? What's the rationale? How will we be convincing if I want to go to Medicare and say, we want some funding to work on this project, and here's why you should give it to us. Because everything essentially comes down to return on investment. I've got to demonstrate to Medicare when we ask to do a project like this, this is what it's going to cost, this is how we're going to do it, and this is why we think it's going to be a good investment for you. So I've got to translate impact into dollars or impact into meaningful human outcomes. And measures of opioid prescribing rates, measures of naloxone availability say something, but they don't really say dollars and they don't really say human life impact directly. But this study gets close to that. What we wanted to do again was kind of come up with some a defensive rationale behind why does increasing access to naloxone matter for the patient population we serve. We looked at Medicare data, we found all of those opioid users in the state, and we said, okay, some of you have received naloxone and some of you haven't. What are the differences between these two groups? What are the differences in terms of healthcare utilization or in terms of outcomes? And the one that we're showing right here is a study that showed that opioid users who received naloxone were half as likely to die of any cause in the year that followed than opioid users who did not receive naloxone. So 50% reduction in death rate. That's pretty staggering. And in my world, that should cause you to ask some more questions. So we wanted to ask some more questions. Is this just an artifact of the data? Is this some statistical anomaly that we're seeing? Or is this something that's true? And one of the ways that you can discern that something's true is you start segmenting your study or segmenting your population a little bit further to try to get rid of some confounding factors. So what if all the naloxone recipients went to, Emory's center and they were fantastic care providers, and it's really just the fact that it's where they went. It's not that they got naloxone at all. So we wanted to try to eliminate some of those potential confounders. So what we did was, and this is what I'm showing you here, is we matched up those opioid users based on risk. So who are high-risk users, who are low-risk users. Now let me ask you this, naloxone recipients, people who got naloxone, would you expect there to be more high-risk or more low-risk opioid users amongst that population? Yeah, that makes sense, right? People at higher risk are the ones who ought to be counseled on naloxone and ought to receive it. I don't have that information displayed right here, but that's something we looked at, and it was kind of just like a confirmation check. If we saw that there was some reason why a whole bunch of low-risk users were getting it versus high-risk, and again, maybe we're measuring this wrong, maybe it's not telling us the truth, but what we saw was significantly higher high-risk users than low-risk users amongst the naloxone recipient population. And we matched this up further to say, okay, so let's take these naloxone recipients and let's compare them to people who are very much like them, as close to an apples-to-apples comparison as we can. And when we did that, we matched up based on age, race, sex, and the complexity of somebody's overall healthcare condition. And that's what's displayed here, is based on comparing like people, that these rates of survival were preserved throughout that. A 50% reduction in death rate when someone receives naloxone or doesn't. So I'm not talking about saving somebody's life. I'm not talking about bringing somebody back from the brink of an overdose. I'm not talking about that life-saving intervention of actually using the naloxone even. I'm just talking about exposure to naloxone. Has this measurable improvement on patient outcomes? And this is a strong rationale for us to propose what are we going to do, how are we going to do it, why are we going to do it, and why does it matter? Now, Henry's looking at his watch and it makes me worried that I've been talking too long. Is that the case? And not getting on it? Just about. So, let me try to maybe speed it up, but maybe not. This is our vision of success, right? This is really simple. So this is just framing on any kind of quality improvement. What we want to do more of is do more things that are better. That makes sense, right? This is just a graphic way to do it. But if we think about naloxone dispensing, there are some impacts that we can predict that would move us along this continuum of where we are to where we hope to be. And some of it are things that have already been enacted, the standing order. There's more product formulations. Narcan wasn't on the market 40 years ago or 5 years ago. Evzio wasn't on the market 7 years ago. Right? So these other formulations that are easier to use are now available. There are mechanisms of making those doses available through community distribution directly to the illicit opioid using population. There are PSA announcements, or Surgeon General essentially stated all Americans should have naloxone. Great, that's a good point blank message, and it really gets to the heart of what we're talking about here, making this more available. But when we get beyond that, we start to hit a wall. And we have to think a little bit further. How do we get our partners to be involved in this? How do we get them to be active in making these recommendations and increasing access to naloxone? And that's the goal. So what we wanted to do was go straight to the source. Who are my favorite people in the world? Pharmacists, doctors, nurses, or somebody else? Pharmacists, yeah, that's not a trick question. That's obvious. We're the best. I want to work with community pharmacies in particular because this is where most people in the community go to obtain their opioids. right? So you go right to the source of dispensing and say, here's a good person we can work with. Here's somebody who's empowered by law to use a standing order and make this other medication available. Here's somebody who's a trusted and accessible drug expert who can have these conversations, just like we have other difficult conversations with patients. So there's a real opportunity, there's a real need, the law supports it. Let's make a project around this. So I'm going to talk a little bit about that project. I'm clicking and nothing's happening, Henry. What do? There you go. How am I doing on time? I'm sorry. 10 minutes left. It's 8 minutes too much, Henry. We can do this fast. Okay, so I'm going to speed up. Forgive me. We're going to have a little time for questions as we go along, but I'm going to talk through a little bit of designing the intervention. So we got to the point of understanding the problem. We got to understanding the best solution. Now, how do we do the best solution? Somebody described to me how many people work at your community pharmacy. Not enough. Perfect. Exactly. That's right. Community pharmacies are thinly staffed, right? One pharmacist at a time, maybe two. Two technicians, maybe full-time, maybe less. Rarely a whole lot more. So thinly staffed, thin in terms of hierarchy of staff members. So when we do work with physicians' offices, we've got physicians to work with, we've got office managers, we've got probably nurse practitioners, nurses, assistants, and sometimes layers below that. In the pharmacy, you got one or more pharmacists, one or more technicians, that's kind of it. The timing is difficult. It's hard to make something that fits into the schedule. It's hard to find the right time and day to do something. So our challenge, first off, was designing an intervention that would meet some of these challenges. That we had to do something that was impactful in a minimal amount of time. We had to do something that created as much flexibility as possible in terms of accessing the information and accessing the sharing of information with those participants. And we had to do it in a way that made a difference, because if you waste somebody's time for more than 1 month in a row, they stop talking to you. And our goal was to work with about 40 pharmacies for almost a year to work on this project of implementing into their practice, how do you screen for opioid risk? How do you identify those patients who are at risk? How do you reliably connect with them to share the information that's relevant and counseling them about that risk, and then making that recommendation and doing it successful to say, Ms. Jones, I think you should have naloxone on hand. So those are kind of the challenges that we need to address in all of this. How do you use that standing order the way it was designed to do to make this drug more accessible? So those are kind of the modules. This is meant to be a monthly sharing call that we would get these recruited pharmacy teams together on, and month by month we will work through this curriculum essentially of starting with quality improvement and working into practice, policy, and kind of guideline implementation in their process. I use this map a lot with the teams I work with because it's a good kind of landmark, and it's a map essentially of where are we going, how are we going to get there. And what this describes is the quality improvement approach to process improvement. And it kind of starts with everybody with some planning stages and then some action stages. But it's important to recognize at the beginning of a project, you're not even on the map yet. We're not even at the point when I get these pharmacy teams on the first call together, or if you're trying to work something in your local pharmacy, you know, day one, you're not here. You're not doing this work yet. You're really just beginning to get ready to do the work. So if you looked online, the information that Dr. Young shared is our quality improvement primer and the team activities that our pharmacies have worked through. So knowing that you have that available to you, I'm going to breeze through this, and knowing that we're probably down to 5 minutes now, I'm going to breeze through this just a little bit. But I'd like to make the point really clear up front is that forming a team is the first step to quality improvement. You don't change a system by just having one person who cares a whole lot work on it. Unless that person is the boss and also does all the work and can, you know, reliably mandate to everybody else that they do exactly as he or she says. Generally speaking, you don't do quality improvement by yourself. You do it as a team. And in a pharmacy, you don't change what all 3 pharmacists do by having one care a whole lot. You don't change what the 3 to 5 technicians do by just having one pharmacist once in a while, you know, really get passionate about this issue. You really do need to have a team approach. So that's where we started. You, Joe's Pharmacy, have signed up on this project. I don't want to just talk to Joe, the pharmacist. I want to talk to the whole team. I want you to think about who's on your team. What are the contributions of your technicians? What are the contributions of your other pharmacy staff? And how can you break up some of the roles in this project to share the workload among them? And next, thinking about how does this project fit with you? You know, have you done other patient service projects? Do you have other advanced care kind of processes in place? Is this something that matters to you? Is it a conversation already amongst your team? Do you work with pain clinics, or do you work in the shadow of a hospital where you're seeing a lot of pain prescribed? So all of these kind of factors change very much the relationship between a participating team and the project themselves. So it's worth considering, and in my mind, it's worth prompting some of that consideration amongst those teams. How's this going to work? What are people's feelings on it? What are their concerns? Where do you think the most opportunity is? And now we're ready a little bit for planning. How do we get this done? And so I'm going to describe real briefly as kind of the foundational approach to quality improvement. We're talking about opioids, we're talking about naloxone, but you can literally plug in any kind of topic here. You got to think about, who are we impacting? What's the group of people that we want to see some change happen in? We call that the population of focus. How do we know if we've made a change, right? How do we know that some difference has happened that's meaningful? So we need to define, how are we measuring what success looks like? We got to know, where are we or where were we, so that we can know later on, wherever we end up, is that better? Is that the same, or is that the worst? So a baseline, knowing this is where we started. And lastly, setting some goals. This is where we intend to be. So this forms really the foundation of planning a project. Who are we going to impact? How are we going to know if we make a difference? And what amount of difference do we hope to make, and when? Henry, I realize I'm close on time, so I'm going to skip a few things. If you'll excuse me, I'm trying to skip ahead. Knowing that y'all have this information, the next couple of steps just kind of walk through some of this thinking of, you've defined a population, great. How do you access them? How do you find them in your data? Because knowing who the people are is not always the same as finding those people in the information that's available to you. So in a pharmacy, that might be running a report, that might be keeping a checklist, that might be some wizardry of computing that I don't even know of, but there's some need to translate your descriptive vision of who, people at risk of opioids, to some actual working definition that you can find. An example of that might be saying, people who take opioids for more than 30 days at a time, and we can run a report. That might be people who use opioids plus benzodiazepines, and we can run a report, we can cross-reference our controlled substance record keeping. So some way that you translate who you're describing into who you're actually seeing. Have you all heard about SMART goals? You heard this term? I see lots of head nodding. I'm not going to belabor that point. But there's a real reason that we talk about SMART goals instead of just goals, and this is a real learning point that almost all teams need to spend some time thinking about, is coaching them on, how do you actually write a goal that means something? How do you write a goal that you can look on in 6 months and say, yeah, we did that, or no, we didn't? Because a lot of goals that get written look like some vague nonsense that you just throw away. So being really clear up front, let's be really specific, measurable, let's make sure we can get it done and it's relevant to what we're trying to do, and be time bound. So we can say 6 months from now, this is what we hope to happen. So I'm skipping ahead here, and let me return to my slideshow. But this is really the nature of what we're trying to move in our project. We're here, we have some amount of naloxone, that's our baseline. We want to do more of it, and the way we're going to get there is by doing better. And how do we do better? We do better one little step at a time, right? So I want to lose weight. I want to lose 40 pounds by August. Trust me, I need to. I want to lose 40 pounds by August. That's a goal statement. That's simple, that's measurable, that's relevant, that's time bound. But it doesn't tell me how I'm going to get it done, right? It doesn't tell you what are the steps along the way that are markers of success that let me know in June, are you doing the right thing, Mike? Or should you redirect and do something different? And that's where we focus on in quality improvement of what we call the PDSA, Plan, Do, Study, Act cycle. And it's a way of framing this iterative improvement, small little tests of change, small little improvements, and they start stacking up to make big improvements. And it's kind of like the saying, how do you eat an elephant one bite at a time. Well, these are your 1 bites at a time, breaking it down into something doable. So this is kind of the next step with our teams, was to say to them, what do you think you can do? What matters to you? You know you want to work on people who are using opioids and benzodiazepines. Okay, what's the first step? And this first step ideally looks like something small. So here's a few examples of what those may be. Was training your staff in developing a policy, so everybody just had a shared understanding. Using bag tags, something that calls attention at the point of picking up to say, hey, here's an opioid, we need to talk to this person. Tracking those high-risk patients through a list, or in one case through kind of an index card Rolodex system of knowing, okay, Ms. Jones came in, and on my index card I can see we talked to her about this last month. We're due to talk to her again and make this recommendation for naloxone today. So all these are real-world examples of how these teams started kind of one step at a time to begin addressing this issue. Forgive me, I'm skipping a discussion, and I'll get to the meat of it a little bit. In a nutshell, I can tell you this project is working. And I'm kicking myself because I looked at this 30 minutes ago and I realized, man, I didn't update that yesterday, and this is from November. And what this would look like right now.
Not mad at you, Spec.